Mo?
Don't mention it.
This is Corey Williams of Johnson & Williams here in Orangeburg, and you're watching New Perspectives on Orangeburg Network Television, Channel 12.
Hi everybody, Harvey Elwood. We're at the Dialysis Access Institute at the Regional Medical Center. We have the pleasure of speaking with the world-renowned Dr. Ross, who is in charge of this facility. Good to see you again, Dr. Ross. I was compelled to come over and talk with you. As you know, I enjoy our conversations so often. You enlighten the public regarding what's going on in terms of health. Not only do you're a 24-hour doctor. You're like the doctors of old who would visit people at their home. We know that you come out to all the churches and various community organizations and groups, and you speak to large gatherings of individuals, talking to them about diabetes and talking to them about healthcare issues and, of course, dialysis. First of all, we'd like for you to tell us what is the Dialysis Access Institute.
Well, the Dialysis Access Institute is a building that we have here in Orangeburg, South Carolina that was designed to take care of the dialysis access for patients. When patients lose their kidney function, we must have a method whereby we can take blood out of the body, purify the blood, what the kidneys used to do, and return the pure blood. To keep these patients alive, what we really need to have is the operations to do that. So it's a way that we can connect the patient to the dialysis machine. Because of the tremendous increase in numbers of these particular patients all over the country, and particularly in our catchment area here, there was a necessity to have a dedicated unit that did nothing but take care of their dialysis access. This institute does exactly that.
Now, why is it here? Why is it not in other medical facilities? Is this the only one of its kind?
This is the only one of its kind where we do everything in dialysis access. It's connected with the Regional Medical Center here. There are certain places that are office-based access centers, but they don't have the capabilities of doing what we are doing here.
Now, primarily what we're talking about for our viewers so they can get a full understanding of this, the various veins or points of entry in order to allow a dialysis patient to receive the dialysis is what we're talking about. How the machinery is accessed to the body. Could that be the arteries in the neck, is it? Or explain to us how that is.
Well, what we basically do with a tremendous number of operations on the arms where we're connecting veins and arteries together, where the veins become very large. All of us have had blood drawn before. Well, the needles that we used in dialysis are somewhat larger than that because we have to get almost a half a quart of blood a minute out of the patient over to the machine and return the blood. So what happens with these multitude of different operations in the arms and the legs is to create a conduit, if you like, a tube, if you like, where they have a good target with a lot of blood going through it such that it can be purified. Now, up in the neck area, sometimes we have to use little catheters. These are little tubes about the size of a straw that go into the big veins in the neck. They actually go down into the heart and come out through the skin. Same situation to get blood out of the body, purify it, and return it.
Vacuum. Now, the question here again, if we have individuals, I've seen from time to time, you see these large, it looks like a large swollen vein. Yes. What causes that, or will this Dialysis Access Institute help to stop that from being an occurrence?
Well, what happens by being cannulated, stuck if you like, so many times, it weakens the blood vessel there, and the blood vessel develops, that swelling is called an aneurysm. That's almost a normal occurrence, and they are not necessarily bad things. Cosmetically, they're not very pleasing, but they're not necessarily bad things. We do have to do operations on these aneurysms frequently to take them down in size because they can get up so large that they can actually rupture. And of course, that, you would have a tremendous amount of bleeding there. But that is pretty much of a normal occurrence to some degree in most patients.
Okay. Now, Dr. Ross, now that we've talked about a portion of what goes on here, we won't go into the training because the world doesn't know, or at least our audience may not be aware, that you're a great teacher. We're going to go into that conversation. We're also going to take a walk around, and you're going to show us some of the facility. You're going to show us some of the young people that travel from all over the country who visit you. I know you're a very modest man, but I want the world to know that. I want our audience to know it. But more importantly, we know the Institute is here. We know what it's doing. We know you guys are learning or teaching people how the procedure of the best way to retrieve the blood and have the blood cleaned and sent back to the body. How are these people getting here? Why do we have such large numbers of people who are on dialysis? That's the question that we need to talk about.
And it's the most important question I think we're probably going to try to answer. The vast majority of our patients have gotten here because of diabetes and hypertension. And it is something that we, in our particular area, statistics have shown, I was told this actually a few weeks ago, that the national rate of diabetes is about 7%. In our catchment here, it is 14.7%.
Double the amount.
It's double. It's absolutely double. And diabetes leads to all kinds of problems all over the body. It's just not a blood sugar problem. It affects every single organ in our body. The eyes, you go blind. The brain, the gastrointestinal tract, the kidneys, the heart, peripheral disease where people have to have amputations done. In our catchment area, we see a tremendous amount of this. It's that we simply have a group of people that seem to, with this large diabetes, more prone to maybe kidney disease than maybe in other places.
Now stop me if I'm wrong. The smaller the blood vessel, the more damage is caused by diabetes. The blood vessels in the eyes, the blood vessels at the lower extremities, the feet, the fingers, and the kidneys, because the kidneys have an awful lot of blood vessels that are back there. And because they're so small, they're damaged through the diabetes. Am I right?
That's correct.
And then somewhere thereafter, the kidney stops functioning properly, and ergo, they have to have the dialysis.
Yeah, every system in our body, every organ in our body is centered around circulation, getting nutrition, oxygen to those particular areas. If we lose circulation to our legs, then indeed you run the risk of having an amputation. If you lose the circulation to the heart, you have a heart attack, brain, stroke. In this particular situation, with the kidneys, just as you said, the small blood vessels start to narrow down, and then the function of the kidney starts to go away. For an organ to function, it must have circulation. We must have circulation. And diabetes is the disease that causes a tremendous amount of this. And coupled with diabetes in our community is high blood pressure. It's a silent killer, as has been said. You don't know what's going on. But even diabetes, by and large, may be relatively silent for many, 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 many years, causing all this damage. And the first time it is diagnosed is when an organ fails, when the patient shows up in the emergency room.
So people very well may not know that in fact they've had organ damage or something's damaging their organs, and they've had diabetes for many years. The best way to find that out is to have regular visits to your doctor, I would imagine.
Exactly.
And to be tested. Diet. I know you talk a lot about diet because we want to see some of this stuff reversed. One of the goals of this program is to help educate the public about the various dangers that are out there in terms of their health and what they need to do. And maybe even to put you guys out of business or slow down your numbers. How do we do that? How do we educate the public and let them know? First of all, be tested regularly for blood sugar and those kind of things. What other advice do you have for them?
Well, I think, first of all, people have to be motivated to want to know. And there's so many of us, I think, that maybe don't necessarily want to know, and if we don't have pain, because that's the big thing that brings people to the physicians, to the emergency room. If I don't have any pain, nothing's wrong with me. But once, and that's what I mean by just silent diseases. They're not causing pain, but they're doing a lot of damage. And so what happens, the first step is going to be motivation to get checked out, if you like. It's so simple to know your numbers, that your weight, your cholesterol, your hemoglobin, your kidney function. We have blood tests that will basically test every organ function in the body. And once that is known, that what are our numbers, now we have to decide what do we do to adjust our numbers. The diet and exercise always will be the first step. If we know that we have too much fat on our bodies, the first thing we need to do is to decide how are we going to reduce that? What are we going to do? Now the motivation comes back to change what we have done, change our dietary regimen, what kind of exercise can we accomplish when we are somewhat overweight. What can we do? People need help.
Dr. Ross, also, and you talked about diet and you talked about exercise. Sugars or foods that are carbohydrates, starches that of course turn into sugars, these are poisonous, I guess, to some degree to our bodies, or the amount thereof.
Yeah, I think that's probably a pretty good description in the sense that it's not like a true poison, but if it is doing injury to organs, I think we could consider that a poison. And I think the sugar intake that we have in the United States pervasively, as well as white flour, even white rice, which is kind of the basic diet that we all grew up on,
Sure.
is one of the huge contributing factors to developing some of these disease processes, particularly diabetes and the obesity triggers other things to happen. So dietary regimen would have to be changed. Not so much in the way of red meats, the fresh vegetables that we all know about, watch your calorie intake, that kind of thing. And there's a tremendous amount of information available to all of us on what we need to do, but then comes the pivotal question, can we do it?
The question here now, okay, we talked about poor eating habits. We've talked about obesity. That is a consequence of poor eating habits. We talked about the consequences of poor circulation and diabetes and the destruction of organs, and then consequently running into having to have dialysis done. How long can a person live, or how long does a person expect to live after they start the process of dialysis? Because apparently the health is failing, things are going down, the kidneys aren't functioning. How long after they begin this process, how long can we expect them to survive?
It's somewhat variable, but no machine is ever going to replace the wonderful working God-given organs that we had. Even the transplants, even though they're wonderful. But on the dialysis machine, even though we're removing lots of the poisons that are built up in our body, we're controlling a lot of the electrolytes such that potassiums don't get too high, the life expectancy of someone on dialysis is certainly shortened, can be shortened significantly, simply because they do not have their own kidney function. The best thing for anyone who has a predisposition for having kidney failure is to, first of all, know that they have it.
Sure.
And if you have a family member, a mother, father, brother, sister, that has gone on dialysis, that potential for anyone in that family group may also be higher, and that we have to look in that family group to say, what can we do to mitigate, what can we do to lessen the chances of that happening to other family members? Because there's a shortened life expectancy, for sure. Number two, the quality of life, having to report to the dialysis machine.
That's 3 times a week, isn't it?
3 times a week.
Wow.
And it's 4 hours sitting in a chair with your arm out having dialysis done. And then you've got the transportation to, the transportation from. So your life somewhat centers around your dialysis.
And the catheters that you have that are inside of you, implanted in you, they have to be maintained, they have to be kept clean at all times.
Exactly.
For fear of infection, you have to make sure that your house is very sanitary conditions in order for you to not have an infection, and then have to come into the hospital to not only deal with the diabetes, but then ultimately having to deal with the infection as well.
Right, and we would have, as you go on dialysis, you would have possibly more problems, certainly with infections, as you said, maybe even more cardiac issues, maybe more problems associated with peripheral disease in the legs. So it starts to build and build and build and build. So kidney failure itself.
Cards.
It is. One thing starts to fall. So even though we do a reasonably good job in prolonging people's life, their life is still somewhat shortened, and as if they did not have the disease, for sure.
Sure. You said something about potassium.
Yes.
Why is potassium a problem to the kidneys? Filtering it out, breaking it down,
It really is. It really is, because the kidney is absolutely an amazing organ on what it does. It adjusts everything. It adjusts the fluid in our body. For instance, if we take in too much fluid, it knows how to eliminate the right amount. If we don't have enough fluid in our body, maybe we exercised in the heat, then it knows not to eliminate fluid, to try to keep us in as good a health as it possibly can. It also does the same thing with electrolytes, potassium and sodium and lots of other electrolytes too. And potassium needs to be kept within a very small range. If it goes too high, it can be quite lethal. Goes too low, it can be a problem. And one thing that the kidney does is that the potassium that we all get in our foods every day, it eliminates the excess potassium, so it stays in a good range for us.
I do know that some people who are heart patients are required to take potassium supplements.
Many times the high blood pressure medicines that they also have to take when they're heart patients actually make the kidneys move more potassium out of the body, so you have to take more potassium in. But when we lose kidney function, our body retains potassium. The kidney can no longer get rid of the potassium, and that's one of the complications that we would see. And many times patients will present to the emergency rooms with extraordinarily high potassium, and they have to have emergency dialysis to get the potassium levels down.
I see. Dr. Ross, we want to thank you for this short conversation. We hope you will take us through and give us a tour and show us some of what goes on in the facilities.
I certainly will.
All right. Thank you.
Thank you.
Yeah, hi. We're prepared to go into the dialysis treatment area with Dr. Ross, but fortunately for us, we happen to see Dr. Gupta. Dr. Gupta, so good to see you again. Tell our audience who you are, how long you've been here, and all the fantastic work that you've been doing for so many years.
I'm a board-certified anesthesiologist, and I run a pain center in Orangeburg. I'm here since the year 2000, and then I started as a locum tenens here in the year 2000, and then I joined as a full-time anesthesiologist in 2007. But I was employed by the hospital from 2004 December as a full-time pain physician. I'm running pain services in the regional medical center as well.
Well, the reason we had to get you on camera is because of the fantastic work that you do. You're a very modest man, but your reputation of excellence precedes you far and wide, and I would have been remiss had I not had the chance to get you on camera. So many people out there in the audience who watch our show are familiar with you. You've been the anesthesiologist. They've been to your pain center, and we definitely wanted to get you on camera, and I wanted to personally thank you for all the great work you've done.
I appreciate it. Thank you very much.
Thank you. Thank you, Dr. Gupta. Inside, and we were observing you, and we observed all of the other doctors that were around you. Tell us what was going on there.
This patient, the graft was not functioning, had a clot inside the graft itself, and we were doing what's called a thrombectomy procedure. This is where we remove the clot, so now she can go back to dialysis. And she's got about a quart of blood a minute going through this access now, so now she can be dialyzed. She'll go right back to the dialysis center.
How many procedures do you personally have to do, or do you do a day?
Well, we do probably anywhere from 18 to 25 a day.
Mm-hmm. And that's you yourself?
Yes.
Wow, that's fantastic. On average, most doctors wouldn't do that much, but I would imagine it's your years of experience and your knowledge of the procedure, because obviously that's why all of these doctors are here, is to observe and watch you.
Well, we've got a place to do it in right now, which is be very difficult in a lot of environments to do the volume because of scheduling the patients, that kind of thing. A lot of the patients that come in with clotted grafts, we don't see them until that morning. Like this particular lady we did a declot on, she came in 30 minutes ago. And now she'll go back to that dialysis center because with all the rooms we have and the capabilities here, we're able to do things fairly quickly.
Dr. Ross, this has really been a great experience for us. It's been a great experience for our viewers, having the opportunity to watch a world-class physician such as yourself, who has so many years of experience. It's been a wonderful experience. We want to thank you so much for this, and we hope maybe you'll invite us back again sometime. We also do know that you work on some of the hardest cases that there are. Why is that?
I'm not quite sure, but that does happen.
Well, they say that you're the best, that's why.
I don't know about that. I have my days.
Dr. Ross, thank you so much.
Thank you so much.